Hey guys, as promised, I'm going to make a quick video overview of the skills that you're going to be required to know and perform not only on your midterm exam and final, but in order to become a successful, competent ENT in general. All right, I know we talked about doing a Zoom call, but I figured this would be more beneficial to you guys. This way you can review the video, you can reference it anytime you may need to going forward. And you can see how everything is supposed to be done, okay? So the skills we're gonna cover is gonna be oxygen administration, setting up your oxygen tank. All right, we're gonna talk about suction. We're gonna talk about oral airway adjuncts. All right, we're gonna go over administering oxygen via positive pressure ventilations with a BVM. We're gonna cover cardiac arrest and AED. And then we're gonna go over a quick overview of appropriate patient assessment up to your CUPS decision. Okay, so first thing we're going to start out with, oxygen administration. Now as you see here, I know with the camera it's kind of hard to see everything in full, but exam day everything will be laid out for you as seen here. All right, every piece of equipment that you need will be on the table. There's nothing that you will not have. All right, you just have to know which piece of equipment is appropriate and find it on the table and use it appropriately. Okay, so starting out with our oxygen administration. Okay, we start out oxygen administration by setting up our oxygen tank. All right, so the first thing we want to do is we want to grab our oxygen tank, full oxygen tank, okay, and we want to inspect it. All right, I'm inspecting the tank itself for any cracks, dings, structural damage, ensuring that there's none of that. Okay, next thing I'm going to confirm that it's oxygen. I know it's oxygen because it has a green top, right? It says oxygen on it, right? It should have a US Pharmacopoeia label on it. If it does not, no sweat. All right, these oxygen tanks are a little bit old. We use them quite a bit around here, as I'm sure you guys know, right? Once you've inspected your oxygen tank, right, make sure it is oxygen, make sure it's safe to operate with. We're gonna crack open the valve stem just a little bit so we can blow out any debris if necessary. All right, you may have an oxygen key, you may not. If not, just verbalize it. That's what we're going to do. All right, as long as you verbalize it, we can say that it happened, right? That's how we know that you know the appropriate thing to do. All right, once you've cleared any debris, you're going to grab your regulator. All right, this is an oxygen regulator. Okay, I know this is an oxygen tank, medical grade oxygen tank regulator, because it has the pin index safety system, right? The 3-prong system. Okay, there's 3 prongs in here, and also it's kind of hard to see on the video, but if you notice, there's a yellow piece there inside, right? That's called a gasket. That is also something that you need to look for. If you do not have that gasket present, when you connect this to the tank and then open up the cylinder, it will bleed, right? It will leak. So we want to make sure that is there as well. I know I went over you guys, you all seem to know and have good understanding of the pin index safety system, all right? Now, next thing we're going to do is we're going to connect this to our oxygen tank, all right? When you're doing this, right, I know it'd be nerves. Take a quick second, take a deep breath, slow down, and look at what you're doing before you apply this, all right? Make sure you apply this the right way, okay? Find the side that has the 2 holes, find where the 2 prongs are, and match the prongs to the holes, okay? So we're going to slide this over, just run it down until you feel the regulator sit into those holes, all right? Then you're going to tighten down the regulator on this side, rotating this screw, right? And just hand tight, right? You don't have to wrench it down, just nice and hand tight, okay? Once that's on, just take a quick look at it, right? If you notice, the regulator is at a perfect 90-degree angle to the oxygen tank. That is a correct placement of the regulator. If the regulator is out of plumb, right, or it's kind of, you know, out of 90 degrees, right, that could mean that you have it on backwards. So take it apart, take a quick look, make sure you have everything the right way, right? But if you have it on correctly, then we can continue. Once it's on, you're going to go back to your valve and you're going to open it up all the way, okay? Once you open it up all the way, you're going to want to verbalize the cylinder is charged now, and you're going to want to verbalize your PSI, all right? I have 2,000 PSI on my full bottle. When I get down to 500 PSI, that's when I'm going to change it if it's not on a patient. If it's on a patient, I'm going to change out my bottle at 250 PSI. All right, all of that should be verbalized, right? That way we know that you know what you're doing, okay? Once this is all set up, everything's good to go. There's no leaks. You've confirmed your pressures, all right? Now I want you to apply a nasal cannula to your patient, all right? Again, you need to pick the appropriate airway device, all right? This is my nasal cannula, okay? Again, if it's not this exact one, look for the two-pronged nose piece. It's kind of hard to miss, all right? These two prongs go in the nose, all right? So I'm going to take my nasal cannula, the opposite end, and I'm going to connect it to my regulator, all right? You may see a threaded coupling or fitting on the regulator. That is not what the nasal cannula goes onto. It goes onto the little tip that is just below the flow meter, okay? So you're just going to push that up and on, right? Put it on there nice and snug. You don't have to, strain yourself, but get it on there nice and snug. All right, and that's when you're going to set your oxygen cylinder to a flow rate of 1 to 6 liters, providing 22 to 44% oxygen. All right. At that time, I'm going to take the nasal cannula and I'm going to apply it to my patient's face. This is key. All right. Most likely, you're going to be starting from behind the patient. All right. So we do not just come over the patient's head and hook the nose. Okay. If you notice, it has this little cinch lock right here. All right, if you just put this straight over their head and go into their nose, there's going to be nowhere to cinch this to. Okay, so what you're going to want to do is, after you plug this in, you set your flow. Like I said, 1 to 6 liters. Have the prongs facing you, right? And now take this whole thing and move it below the patient's chin, okay? Now come back towards you with the prongs into the patient's nose, all right? The 2 bunny ears that you have in each hand, wrap that around the ears, all right? Notice my little cinch is still under the patient's chin, all right? Now, I just cinch down the cinch lock, and it remains on the patient. Got it? Once you've done that, if prompted, to switch over to a non-rebreather. We're going to go ahead and we're going to take this off. All right? You can shut down your O2, put it back to 0, take this off, and get our non-rebreather. All right, remember, the key is we never put a mask on a patient's face unless there's oxygen flowing through it, okay? We don't want them to feel smothered, all right? So again, we're gonna plug it into the same exact port as we did our cannula, but as I stated, when we set our oxygen, our liters per minute for the non-rebreather, we're doing it at a minimum of 15, all right? I know there's a range, but my recommendation is stick with 15. You'll never go wrong with 15. All right, you're still delivering a high concentration of oxygen either way, right? As I stated, very important, right? You will be wearing PPE when doing this, okay? All of your skills, minimum of glasses and gloves, okay? You must fill the reservoir bag before putting this on the patient's face, okay? So once oxygen is flowing through it, right, you're gonna take your gloved hand and you're gonna put your finger over the reservoir bag, and this is gonna fill up. You're gonna verbalize this, right? There's not actually oxygen here, so you're gonna verbalize, I am going to fill up the reservoir bag by covering the port with a gloved finger, right? If you do not do it that way, you can also verbalize, I'm going to fill up the reservoir bag, and I'm just gonna pinch the nose cup from the outside with a gloved hand, occluding the bag, so that backflow fills up the bag. Once the bag is full, we are now ready to apply our non-rebreather, okay? So, here's our strap. It's going to wrap around the back of the patient's head. All right, and the key here is once you have the non-rebreather over the bridge of the nose, you're going to want to pinch the nose crimp, right? Once that's on, verbalize that you check for an adequate seal and you do not have any leaks. At that time, you'll be prompted to discontinue the oxygen via the non-rebreather and disassemble the oxygen tank, okay? So you're gonna take the non-rebreather off the patient, unhook your non-rebreather, and you can do a couple things at this time. You can shut off the flow meter, right? But you're gonna have to open it back up. So remember, as I stated when we spoke last time on Zoom, this is, even when you shut this tank off, this is still pressurized, so we have to relieve the pressure. So this is very simple. With the flow meter still blowing out oxygen, take your oxygen key, close off the bottle. Once this is completely closed, this is still gonna relieve the pressure that's within the regulator. And once this stops, you stop hearing air come out of this, that means the whole system is depressurized. And all you gotta do is now you can take your regulator off, okay? So I'm gonna leave this connected for the BVM example, all right? That in a nutshell is your oxygen, okay? Oxygen setup and administration, all right? Everything I stated, you're gonna wanna verbalize, okay? So let's talk a little bit about our airway adjuncts, all right? This is my OPA. This is my NPA, okay? OPA stands for oropharyngeal airway, NPA stands for nasopharyngeal airway. Contraindications to my OPA. Gag reflex or a conscious patient. Indications, no gag reflex, unconscious cardiac arrest, okay? Proper insertion technique at a 90-degree angle. Well, before that, we need to measure it, right? So the appropriate measurement technique from the corner of the mouth to the angle of the jaw or the mandible, right? Once we've done that, appropriate insertion technique, open the patient's mouth using a scissor technique, or you can just grab the patient's tongue, take the OPA in the corner of the mouth. As you're inserting it, rotate it away from you towards the patient's chest and push it down. When the flange of the OPA is at the teeth, as it is there, that is correct. If the OPA is like that, that is incorrect, right? You either haven't pushed it down enough or it is inappropriately sized, okay? So now my OPA is in, all right? That's how you appropriately insert an OPA, and those are the most pertinent indications, contraindications, and things you need to know about your OPA, okay? When we're talking about the NPA, right, we want to make sure that we lube it up, all right? Measure it from the corner of the nose to the tragus or to the earlobe, all right? Once we've measured it and it's lubed up, we're going to go bevel toward the septum. So bevel side is going to go toward the septum of the nose, right? Whether you go right or left there, that's up to you. But we're going to go bevel toward the septum, and we're going to insert the NPA. If it's difficult, you can spin the NPA. It'll facilitate insertion. And you are going to insert it until, once again, if you notice, I know it's kind of hard to see here, but the flange is at the base of the nose. All right, that is this. That's incorrect, okay? All right. Your indications for your NPA are going to be patient with an intact gag reflex, okay? Your contraindications are going to be head trauma, where you're suspecting some sort of basilar skull fracture. That's a key term, right? Basilar skull fracture, right? Anytime you see bruising behind the ears, right? Two black eyes called raccoon eyes. The bruising behind the ears is called battle signs. Anytime you see battle signs or raccoon eyes, and or you have fluid coming from the ears, the nose, and or the mouth, those are all signs of a basilar skull fracture where you would not want to use the NPA. Okay, otherwise you can use an NPA, you can use an OPA, you can use them both. All right, so next, this is probably the suction unit, right? Most of our suction units are like this unit. our first step when we suction, right, is turning on the suction unit, right? The on button is right here. Obviously, it's not charged. We verbalize this. Remember, a lot of this is verbalization. So everything you hear me saying, you should be verbalizing in your own way, okay? First step, turn on the suction unit, right? You are doing upper airway oropharyngeal suctioning. So you will have a hard Yankauer suction catheter, rigid tip, right? This is your suction tubing. So one end of the tubing, both ends are the exact same. One end of the tubing goes into one side. The other end of the tubing plugs into your suction canister. All right, so now I'm set up, my unit is on. Now I want to set my pressure. On this unit, there's only two pressures, a high pressure and a low pressure. And it states right here, when this button right here is pushed in, it's on its highest pressure. When you pull it out, see, out, that's out, that's in. When it's in, it's at its highest pressure. When it's out, it's at its lowest pressure, only about 120 millimeters of mercury worth of pressure. So you're gonna want to run this all the way in for oropharyngeal suctioning, right? Put your suctioning numbers, reference those to your book, somewhere around 300 to 350, if you're gonna verbalize numbers like that, okay? So once you have the unit turned on, you have your equipment set up, you've set your pressure. Last thing we're gonna do before we suction is check that it's working. So if you notice there's a little burp hole right here, this will not suction unless this is covered up, right? It's relieving pressure right now, right? So I have to cover this up in order for it to create a vacuum. So the way that I test this is I take my gloved hand, take my suction catheter, I cover the hole, and you can feel it on your hand. You should feel a little bit of suction, right? Vacuum. Cool, I know it's working. Awesome, right? So now for my patient that needs suctioning, right, the cue here is I'm going to insert the suction catheter into their oral pharynx just as far as I can see the tip of the suction catheter. I don't want to go any deeper. When I can no longer see the tip, I'm going to cover the hole. Remember, we enter the mouth without covering it. We don't want to suction as we're going in. We wait till we get in as far as we're going to go, then we cover the hole and suction as we pull it out. And when we pull it out, we want to suction in a circular motion to try to cover as much surface area of the airway as possible, right? And we do this for no longer than 15 seconds. Once you've cleared the airway, you're going to go back to bagging for 2 minutes and then assess for more secretions after the fact, okay? So that's your suction scenario. If you have to suction as part of your BVM skills station, right? No big deal, okay? Patient vomits, patient starts to have secretions coming up. What are you gonna do? You're gonna put them on their side. You're gonna go to your suction canister. You're gonna make sure it's on. You're gonna ensure everything is hooked up. You're gonna set your pressure. You're gonna test it, and you're gonna suction, right? Suction for 15 seconds, take it out, go back to bagging, right? Resume bagging. No big deal, all right? So that's our suction, our OPA, and our MPA. Next, we'll do the BVM, okay? Now, this particular BVM doesn't have oxygen tubing, but again, I will verbalize it, all right? Part of this is knowing exactly what you need to do. If you know what you need to do, then you can see if you know what right is, then you can see what wrong is. So you just verbalize what is appropriate, right? So let's say I have a patient found unresponsive, laying down on the side of the road in a field, bystander, they're too afraid to go approach the patient. They can't tell if he's breathing, if he's alive or not, right? So we're gonna start out BSI scene safe, right? That's for everything, for every skill. We wanna make sure we have our BSI, and that's everywhere in real life, okay? We always wanna protect ourselves. So BSI scene safe, right? I approach my patient. When I get up to my patient, right, the first thing that I'm gonna do is I'm gonna check for responsiveness. Hey sir, are you okay? No response, all right? When we have no response, our next step is going to be to check a pulse and check for breathing, right? So we're gonna feel for the carotid pulse, we're gonna look for chest rise, we're gonna listen for breathing, okay? When we feel for a pulse, we don't feel for less than 5 seconds and no more than 10 seconds, all right? Well, in this case, my patient has a pulse, but my patient is not breathing, okay? At this time, I'm first going to adjust the patient's airway and position him in the sniffing position, right? I want to align his airway axis and I want to make a good path for airflow, all right? And then using the head tilt chin lift if you don't suspect trauma, or the jaw thrust if you suspect trauma, right? Right at that jaw joint, that temporal mandibular joint, just articulate it up, open his airway, and look, right? Remember, we should not start ventilating before we look in the airway, right? Not to mention, if we position them correctly, that might stimulate spontaneous respirations, right? And we might not have to bag him, right? Maybe that's all he needed to regain consciousness, right? Maybe it was a positioning issue. So, point is, we're gonna sniffing position, inline stabilization, open up the jaw with the jaw thrust or the head tilt chin lift, and we're gonna look in the airway for any secretions or possible oral airway obstructions. No obstructions noted. At this time, I'm gonna grab my BVM. And again, for about the first 30 seconds, it is okay to administer breaths without oxygen or an OPA, right? But after about 30 seconds to a minute, I wanna make sure that I am on oxygen, right? Let's go with 30 seconds, no more than 30 seconds, right, that we're bagging. I wanna make sure that I'm on oxygen, right? So if you can do this right away too, right, if you choose to, right? But we wanna get some air moving in this guy. So 30 seconds initially, get him some airflow, then let's verbalize, let's make sure we get our oxygen tubing connected to our oxygen tank, again, at the same spot as everything else, right? And then I'm gonna set my flow again, 15 to 25 liters with this. This is delivering 100% oxygen, all right? So that's what you wanna tell your proctor, hey, I'm gonna start bagging on high flow oxygen at 15 to 25 liters a minute, giving 100% oxygen, right? At this time, I'm also gonna insert an oral airway adjunct. This is key, right? We need this oral airway adjunct to displace that tongue. So just like you put that oral airway adjunct in, just like I showed you, right? Does the patient have a gag reflex? No gag reflex, right? Okay, good. If he has a gag reflex, no big deal. Take this out, put the NPA in, right? If he has a gag reflex and he starts vomiting, take this out, rotate the patient to their side, go through the suctioning I just showed you. When you're done suctioning, okay, the patient is now suctioned. Let me throw my NPA in now, and I'm going back to bagging, right? No big deal, guys. You guys know what to do. You just have to do it, right? So once you get your adjunct in, right, NPA or OPA, right, you're going back to bagging, okay? Rescue breathing for an adult is 1 breath every 5 to 6 seconds, right? So 1, 2, 3, 4, 5, 6, 7, 8, right? So on and so forth. You notice you're counting out a real 5 to 6 seconds, right? We don't want to be too fast. We don't want to be too slow. Another thing, if you notice when I squeezed, right, just enough to get chest rise, all right? Let's see if you can see here. You can see a little bit that long. I barely even squeeze this back, maybe halfway, right? There's a lot of oxygen in this device. We don't need it all, okay? So just enough to get that nice chest rise. I know I've administered a good breath, right? Notice single person bag technique. I'm using the CE technique, okay? So my index finger and my thumb make a C around the mask, right? And then my other 3 fingers articulate the jaw up and into the mask, okay? This is key where people make a lot of mistakes in bagging, as I was telling some of you the other day, okay? A big thing where we fail is mask placement, right? And our technique for anchoring the jaw and keeping that airway open, right? So what I would tell you to do, either way, whether you're by yourself or a 2-person, whenever you're going to place this on the patient's face, all right, take your mask and pull it apart, right? This is elastic. So when I let go of it, it's going to want to recoil back to formation, right? So meaning that's important here, because if I do that, right, I want to put the tip of my mask, I want to start at the level of the pupils on the bridge of the nose. I want to pull this apart, okay? I'm going to put it at the line of the pupils, and I'm going to roll this down the patient's face. All right, when I get it covering the patient's face, I'm just going to slip my fingers out, and what's going to happen is this mask is going to try to come back to its normal size, and it's going to almost create a suction on the patient's face. Right, you want to set yourself up for success? That's the best way to set yourself up for success, right? Then I'm going to use my 3 fingers, and I'm going to lift the jaw up, pulling the jaw into the mask. That's another key, okay? What too many people do is it's very intuitive to lean into the mask and push into the mask, or into the face, into their face, right? What happens when we do that is we smush all of their soft oral facial tissues together, and we actually end up occluding their airway, right, and fighting ourselves. Okay, so remember, it's pulling the jaw into the mask, not pushing the mask into the face, right? So once you've verbalized everything you know about bagging and what we're doing, right, if we introduce a second rescuer, what I want you guys to do is say, I'm going to use that second rescuer to assist me in two-person ventilation, right? I am going to direct my rescuer to take the BVM mask and pull it apart. Put the tip of the mask at the line of the pupils. Roll it down the patient's face. Pull out his fingers. It's going to create a suction, right? Then I'm going to advise him to create the mask seal with both hands, right? You can use the double CE technique, right? If you want to, you can verbalize you're going to use the double CE. That is just fine, right? But what I like even better is the 2 thumbs down technique, right? And what that looks like is after you pull your fingers out of the mask, you just leave your thumbs where they're at, right? And now you have all 4 fingers to grab this jaw, right? And now you find the joint of the jaw, and now you can really pull up on this, right? So you get a better harness and anchoring at the jaw, right? A better grip. That's number 1. But number 2, if I'm using a double CE, there's 2 complications that I run the risk of doing. Especially if I'm not as strong of a person. If I'm pulling up on the jaw and I'm really digging in with these 3 fingers, right? All of this here is soft tissue, right? If I push too hard, I'm going to push the tissue and occlude the glottic opening, right? A little bit, right? Potentially. Secondly, when I'm pushing this way, like I'm doing a push-up, this is very intuitive, right? I have a lot of leverage here, and naturally I want to push into the patient's face. Once again, squishing their facial structures together. So again, the double CE is not wrong at all. It's a perfectly acceptable technique. Just be aware of those things and manage it if that's what you choose. The thing I like about the 2 thumbs down technique, right, is this part of your hand is called the thenar prominence, okay? And the way the mask is shaped, right, when I have my thumbs like this, I don't have a lot of leverage. So it's not very intuitive for me to push down because of the slope of the mask, right, and I don't have my hands wrapped around it. If I push too hard, I feel like my hand's going to slip off, right? So this is going to give me light pressure in, but it gives me all my fingers to really grab the angle of that jaw, right? Take these and pull the face into the mask. That is the goal. We want to pull the face into the mask, okay? And if you guys could see it, you would see how beautifully open and patent this patient's airway is, right? So that's how, one of the 2 techniques, either way, you just need to walk your second rescuer through how you want them to hold the mask and how you want them to assist you with 2-person bagging, okay? If you are gonna do the mask, then you just verbalize how you would do it, one of the couple ways I just showed you, all right? Cool. That's pretty much it for that. When it comes to your CPR and AED, guys, it's just like when you took CPR. Okay, no different, right? Except you may have Johnny the mannequin here, right? I'm not going to go down the whole laying him down, but I'll basically run through how it should go for you guys, right? But you guys should move this patient to the floor and start administering compressions when you're going through your scenario, right? We do all scenarios as realistic as possible that we can, okay? So again, same type of scenario, man down patient. When you approach them, we're BSI and our scene safe, and the first thing we always do to any unconscious or unresponsive patient is check responsiveness, right? No response, right? Any unresponsive patient, we always check a carotid pulse first. This time you check for a pulse, you check for breathing, right? The patient has no pulse and is not breathing. Again, you did not witness this incident. So what you're gonna wanna do is 2 minutes of CPR if you're by yourself, notify the emergency response system, right? And try to find an AED, all right? If you have a partner with you, initiate CPR, have them notify the emergency response system, call 911, and find you an AED, right? At this point, this is when you're gonna move your patient to the floor, if they're not already on the floor, and you're gonna start doing chest compressions, all right? I'll use the mannequin to illustrate the chest compressions. You will not do it on this guy though. It will be on a full mannequin, okay? Keys with chest compressions, and a couple pet peeves of mine, right? The base of your palm, right, the butt of your hand needs to be around the nipple line, okay? Mid-sternum, all right? Your other hand interlocks over the top with your fingers, all right? Now, here's where people tend to go wrong. They take their bottom hand and they wrap their fingers around the chest wall. That is inaccurate. That's not correct. It's not appropriate. You lose pressure that way, right? You create more surface contact, and by doing that, you reduce the amount of pressure you can apply. So keep your fingers off of the chest. It should just be the heel of your hand, right? At the nipple line, mid-sternum, okay? Once we have good hand placement, we're gonna get directly over top of the patient so that, again, we are square over the chest, right? We wanna use our upper body to assist us with compressions, right? We don't wanna just use our arms, we wanna use our upper body. So once we're placed right, we're positioned right over the patient. I'm gonna start my chest compressions on an adult patient at 30 to 2, right? I'm gonna do 30 compressions to 2 breaths, right? And you're gonna start your compressions, right? And verbalize while you're compressing, 30 to 2, right? I'm gonna do this for 5 cycles. I'm trying to achieve 100 to 120 breaths in a minute. I'm going to compress the chest at minimum of 2 to 2.5 inches, or 1/3 the depth of the chest. In between each compression, I'm gonna ensure that I'm allowing for complete chest recoil and the ventricles to fill up. So when I compress again, there's plenty of blood to be circulated throughout the body. All right. Now, once you tell me everything you know about CPR and you perform a cycle of CPR, your AED is going to arrive, right? So while you are continuing CPR, you're gonna open up the AED, right? The very first thing we're gonna do, as you all know, is turn it on, right? And follow the prompts.
Apply pads to patient's bare chest.
So we're gonna apply the pads.
Pads connector next to flashing
Second,
light.
we're gonna plug in the pads.
Analyzing heart rhythm.
Stop touching the
Do
patient.
not touch the patient.
I'm clear, you're clear, all clear.
Shock advised. Charging.
Continue CPR. When it says charging, we go back into
Stay
CPR.
clear of patient.
Now it's charged. You're clear, I'm clear, we're all
Deliver
clear.
shock now.
Deliver
Press
shock
the
now.
orange
You're clear,
button
I'm clear,
now.
we're all clear.
Shock delivered.
Continue.
Begin CPR.
Begin CPR again. So really, guys, once you've turned it on, it's pretty freaking easy. Follow the prompts, right? The big thing is, remember, you know where to put the pads, all right? And if you don't know, it's firefighter proof. Everything is written in pictures and colors. And as you can see right there, that shows you where to put the pad, right? That pad would go in the upper left on the pectoral, and then your other pad is gonna go, one pad's gonna go up here. Now this is, when you're looking at this, it's gonna look like your left, but this is my right. All right, it's gonna look like my left, but this is my right, okay? And then the other pad goes down just below my chest on my left side, okay? So the AED scenario is very simple, very easy, very quick. One thing I'll tell you is after 2 minutes of CPR is up and it analyzes again and it says no shock advised, make sure that before you go right back into CPR, you check for a pulse, right? Because you only shock 2 rhythms, and if it doesn't advise a shock, it could mean that the patient has a pulse. They may not have a pulse. In that event, you'll just continue CPR again, okay? So that covers that one, all right? And the last big scenario that we're gonna go over and that you'll be evaluated on is gonna be our medical patient assessment, all right? So you'll have a mannequin, maybe in a chair, maybe on a stretcher, all right? We're only being tested up to cups at this point, guys, so we don't have to go past our transport decision, right? But we do have to get through our primary assessment, all right? So what I'm gonna review for you real quick is the appropriate way to do a patient assessment and complete the primary assessment, all right? So again, initially, right, I give you a dispatch, you'll get a dispatch. You're en route to a 65-year-old male patient. Chief complaint is chest pain, all right? Go, okay? BSI, scene safe. I got my gloves on, I got my glasses. I'm gonna ensure that the scene is safe, right? Confirm it's safe, boom. I'm going to confirm whether this is an MOI or an NOI, all right? In this case, we're going with this is an NOI, all right? I want to look to see how many number of patients I have. Do I only have one patient? Yes, we've only got one patient, all right? I want to check to see if I need any additional resources and request them as needed. At this time, no additional resources are needed. You have partners to assist you, ghost partners, real partners, whatever the scenario dictates, all right? And I would consider C-spine based on the nature of the call. This is not a trauma call. So unless otherwise noted once I arrive on scene, at this time I'm not considering C-spine or thinking that it is necessary. All right, that's the very first part. We knocked that out, right? That's the first section. Next, I'm on scene now, right? As I walk into the residence, I'm approaching the patient. What is my general impression of the patient? And do I notice any obvious life threats? Right? That's very key, because if you notice an obvious life threat, i.e. bleeding, right, we want to take care of that, and that's going to change our order of our ABCs, right? No, you don't notice any obvious bleeding. The general impression of your patient is he's sitting up, awake, he looks at you, he acknowledges your presence as you walk in. Doesn't appear to be any obvious distress that you can see from a distance. Cool. Once you make contact with the patient, the first thing you want to do, good evening, sir. My name is Scott with First Response Training Group. What seems to be the problem today? What'd you call us out here for? Well, I'm having chest pain. Okay. Do you mind if I ask you a couple of silly questions? Sure. What's your name? What's today? What month is it? What city do you live in? What is going on? Why are we here, right? Once they can answer all those questions for you, they are alert and they are oriented times 4. And they are alert on the APLU scale, right? Okay, so they're alert and they're oriented. All right, got it? So now I've taken care of their general impression. I've ruled out life threats immediately at the moment. Their disability is alert and they're oriented. So they have an intact, mental status. Check. All right. Sir, do you mind if I assess you? Yes, please do. All right, the patient is talking to me. First, his airway. Patient's talking to me, so I know his airway is patent. Right? Check. We're done with airway. Next, I'm going to move on to breathing. Sir, is it okay if I assess your chest and expose you a little bit so I can assess? Yeah, sure, no problem. Right? We always want to try to get consent. Okay? So in this case, yes, that's not going to be a problem. So when I'm assessing breathing, right? As I'm assessing breathing, does the patient have equal chest rise and fall? Yes, he does. Right? What is the patient's work of breathing? Do I notice any intercostal retractions in the chest? Do I notice any sternocleidomastoid muscle use in the neck? Do I notice him using extra belly muscles to breathe? No. What is his rate? How does his rate appear? Fast, slow, whatever, normal. But you want to check for the rate and the quality of the breathing. You want to ensure that you talk about all that and inquire, right? Next, I'm going to listen to my lung sounds. At least 4 fields of lung sounds, or 6. All right, listening for anything adventitious, right? All right, do I see anything on here I need to seal or stabilize? No. All right, I'm going to put this patient on 2 liters of nasal cannula oxygen based on his complaint. All right, you never go wrong with putting the patient on oxygen. We know in real life that that's not realistic, right? Sometimes it's better to not, but you want to make sure that we verbalize it, all right? Because we always need to consider oxygen for these patients, all right? So, again, you can do the method I showed you, or we can go through the OI pass, right? I'm going to put the patient on oxygen. That's my O, 2 liters nasal cannula. Sir, is it all right if I look at your chest? My I, I'm going to inspect, right? I'm looking for that chest rise and fall. I'm looking for retractions. I'm looking for any bruising, right? Any wounds, any patches, anything like that, right? That's my inspection. Anything that could tell me something about the patient, right? I'm going to palpate. That's my P, right? Palpate down the clavicles, down the sternum, under the breastbone, the rib cage. Have them take a deep breath in, see if there's any pain, right? A, auscultate. That's where we listen, right? And then S, is there anything to seal and stabilize, right? That would be more for a trauma scenario, so that's inevitably going to be no for a medical call for the most part, right? That would require there be an open wound. If there was something to seal at least and stabilize, generally we're considering flail segment, right? That's what we're ruling out, multiple rib fractures in multiple spots. but this is a medical call, so that's not gonna be applicable, right? So once I clear my breathing, okay, next I'm going on to circulation. Part of my circulation assessment, right? Radial pulse, big one. When I'm assessing the radial pulse, what's my rate, rhythm, and quality? Make sure you ask your assessor, right? It's fast, it's strong, and it's regular. Okay, what's my skin condition? How does he feel? Is he cool? Is he warm? Is he hot? Is he cold? What's my condition? When we're talking about condition, is he dry? Is he clammy? Is he diaphoretic? Right? And then what's my color? Is he pale? Is he gray? Is he red? Right? So circulation, radial pulse, and then skin color, temperature, and condition. We need to ask about all those things, right? We need to feel for the radial pulse. We need to inquire about rate, regularity, and quality. Skin, we need to inquire about the color, the temperature, and the condition, right? Remember, color and temperature are pretty self-explanatory, but condition means, right, are they sweaty, right? Are they dry, right? That's your condition, right? Last part of our circulation is going to be our voids, all right? After I've done my radial pulse of my skin, I'm going to check my voids. The voids are behind the neck, behind the lower back, behind the knees, and under the ankles, right? Those are all void spaces where we may not have otherwise seen anything immediately when we approach the patient. There may be bleeding. That's what we're doing. We're checking for bleeding, okay? Once we've cleared our ABCs and we run through all three, right? Now we make our transport decision. Is this patient stable, potentially unstable, or are they unstable? Choose whatever you feel, whatever you know in your mind, based on your primary assessment and the complaint of the patient, and make your transport decision, and you'll be done, right? That's going to complete your medical patient assessment for now, all right? As we move forward in the program, we're going to get deeper into medical patient assessment to where we will perform a complete patient assessment. All right, guys? So hopefully this helps you out a little bit. If there's any confusion or you have any questions, again, you can always feel free to contact me on JV Learning or just text me in the group chat that we have set up, guys. All right, good luck, study, and maybe we'll see you next week for your midterm.